Let's talk about seizure disorders, something every nurse needs to be confident about. Seizures aren't just about convulsions or people dropping to the floor. They can look like a subtle stare, a strange smell, or even an odd repetitive motion. And the underlying cause? It's a sudden, excessive electrical discharge in the brain. Think of it like a lightning storm inside someone's head, and the type of storm depends on where it starts and how it spreads. Now, if someone has one unprovoked seizure, we watch closely. But if they have more than one, that's when we begin to call it epilepsy, according to the International League Against Epilepsy. We break seizures down into three broad types. 1. Focal onset seizures. These start in one part of the brain. The symptoms match the area affected. So if it starts in the motor cortex, you might see jerking in one limb. If it starts in the temporal lobe, maybe odd smells or déjà vu. 2. Generalized onset seizures. These involve both hemispheres from the start. That means both sides of the body are typically involved, and these are the types more commonly associated with tonic-clonic convulsions. 3. Unknown onset seizures. This category is for when we just don't have enough data to classify it yet, like if no one saw the beginning or if it wasn't caught on EEG. There's also a distinction between provoked and unprovoked seizures. A provoked seizure might be due to alcohol withdrawal, low sodium, a fever in a child, or even a toxic exposure. Unprovoked? That's when there's no clear acute trigger. Now let's talk pathophysiology. What's really happening here? It's a disturbance in electrical activity, an arrhythmia of the brain. These nerve cells, instead of sending organized messages, fire off abnormally and excessively. The result? You can get anything from a blank stare to full body convulsions. Seizures can be genetic, structural, metabolic, or from unknown causes. Think brain tumors, CNS infections, trauma, stroke, toxins, electrolyte imbalances. The list is long. You don't have to memorize every cause, but you do need to think critically when someone has a new seizure. So what does it look like clinically? It depends. A generalized seizure might start with rigidity, followed by jerking, what we call tonic-clonic. Patients may let out a cry, chew their tongue, lose bladder or bowel control, and drop into a deep sleep afterward. This postictal state is marked by confusion, fatigue, maybe even a headache or muscle soreness. A focal seizure, on the other hand, might look like a lip smacking, a hand twitching, or a brief, confused episode where the person stares and can't respond. They may or may not lose awareness. What about diagnosis? We need a full picture. How often do the seizures happen? What triggers them? What do they look like? We take a developmental and medical history, ask about head injuries, infections, drug use, birth history. Then we run labs, metabolic panels, toxicology screens, and most importantly, we do EEGs to look at brain activity. Sometimes we need an MRI to look for structural lesions like tumors or scarring. Some patients get video EEG monitoring over days, especially if surgery is being considered. One more diagnostic tool is SPECT scanning, which helps us find where in the brain the seizures are starting, especially useful before epilepsy surgery. Let's shift to nursing management. Your role is crucial. During a seizure, you're the eyes and ears. What happened before? Was there a trigger? An aura? Where did the seizure start? Did the hand jerk first? Were the eyes deviated? How long did each phase last? Was there incontinence? Automatisms like lip smacking? Was the patient responsive afterward or confused? We need all those details documented because that helps guide treatment. Now, here's what you do during the seizure. Keep the patient safe. Ease them to the floor if standing. Move objects away. Don't restrain them, and don't put anything in their mouth. Turn them on their side if possible to help with secretions. After a seizure, the focus is on recovery and preventing complications. The patient may be hypoxic, so maintain a clear airway. Suction if needed. Continue placing them on their side. Make sure the bed is low and side rails are up and padded. Monitor vitals, reorient them, and let them rest. This is also the time to assess for injuries, especially tongue bites, fractures, or head trauma from falls. Talk to the patient and the family. Seizures can be terrifying, especially for those witnessing them for the first time. And don't forget the emotional side. Patients often feel embarrassed, confused, even depressed. Offer reassurance and make sure they know they're safe and being cared for. In summary, seizures are a symptom, not a disease, and they can take many forms. Diagnosis requires detailed history and neurological testing. Nursing management during and after a seizure is about safety, observation, and support. Emotional care matters just as much as physical care.